today. Before we start the session today, I'd like to encourage everyone to pause and look out a window if you have one nearby and think about where you are and the sky and the land around you. Recognizing, of course, that your view in the Toronto area today will be a lot of wetness and bad weather. ICS is located on the traditional territory of the Wendat, the Haudenosaunee Confederacy, the Anishinaabe, including the Chippewas, the Mississaugas of the New Credit. Toronto is host to many First Nations, Métis, and Inuit peoples, and is within the territory of the Dish with One Spoon Treaty. We give thanks to the nations who we live and have lived and protected their territory against colonization, historically and today. I'm pleased to introduce our presenter for today's session, Dr. Arjumand Siddiqi. She will present a primer on key concepts and issues that have been developed in the scientific literature on health inequities. She'll also reflect on the state of Canadian research in this area, with an emphasis on key challenges and opportunities. Dr. Siddiqi is Professor, Division of Head of Epidemiology and Canada Research Chair in Population Health Equity at the Dalla School of Public Health, University of Toronto. She holds appointments at the Harvard T.H. School of Public Health and Gillings School of Global Public Health at the University of North Carolina, Chapel Hill. Dr. Siddiqi's research focuses on how policies and other societal conditions explain health inequities, particularly how they arise, why they persist, and what might change them. She's also working on philosophical implications of work in this area. Dr. Siddiqi received her doctorate from Harvard University, and we're thrilled to have her join us this afternoon. As a final note, please remain on mute during the presentation, but feel free to unmute and turn on your camera for any questions. You can use the chat box or raise the hand function as needed. Now I'll formally pass the presentation over to the ICS team and Arjumand.
Thank you so much, Sue. I really appreciate that very kind introduction. I don't know if the ICS team has anything else they want to say before I start, or should I just get going?
Great. No, thank you so much, Sue. And thank you so much, Arjumand, for joining us today. We're really looking forward to it.
Great. Thank you. So great to be with everyone. I see quite a few people's names who I recognize and some new ones. So it's really a treat. So I was asked to talk about health inequities, and there's lots of different ways you can go with this. And what I thought I would do is use this not as sort of a definitive presentation, but maybe just one that brings up what I think are some core issues and maybe some core assumptions, working assumptions that I think we often forget about. And so I thought maybe this would be a chance just to open the dialogue, open the conversation, and then sort of take it from there in the future. So let me share my screen. So I'm going to focus on two types of inequities today. One is socioeconomic and the other is racial, and talk a little bit about how they're related to each other. And just a little note about nomenclature, which I think we often talk a lot about, especially in Canada. Are we talking about health inequalities? Are they health inequities? Are they disparities? I think, the quick and dirty is that inequalities just mean health differences, and health inequities mean that they're differences that rise to the level of an injustice. So they are differences that occur because of injustice. But and that's also true for disparities. But in practical terms, these concepts are used interchangeably. And I know we sort of have this very strict thing about how we should be calling things inequities because we want to emphasize the justice component, and that's fine. But I think, we could have an argument about whether there's any other way to perceive a social difference in health. And so therefore, an inequality on a social level is, tantamount to an inequity. And the fact that in practical terms, but all these terms are used interchangeably. So just wanted to flag that. Okay, let's talk a little bit about socioeconomic health inequities. And in the Canadian context, Canada's been really active in trying to understand how socioeconomic health inequities develop and what they look like and why they occur. This is a book from a long time ago, decades ago, called Why Are Some People Healthy and Others Not? And it was one of the first real modern day pushes to bring onto the radar, back onto the radar, this idea that people differ in their health status for many reasons, but at some level, the major way you see health patterned is across social variables, and they focus largely on socioeconomic conditions. And if you look at, I guess I should go to slideshow here. And let's see. If you look at Canadian research over the years, we have done a lot of work to try to describe socioeconomic health inequalities. And I found this early paper on the ICES website, actually, where these authors looked at socioeconomic differences in something called the Health Utility Index. And so if you look at the graphs produced in their paper, they probably look very familiar. On the left side, they've looked at differences in health utility index scores by educational attainment. On the right, they've looked at it by income. They split by age and gender. And what you see in both graphs is effectively a sort of stepwise gradient across educational groups or income groups. And that is kind of the signature pattern of socioeconomic health inequities. It is a stepwise gradient across levels of socioeconomic conditions. And it's true for men, it's true for women, it's true across age groups, and so on and so forth. But the idea is that there's usually no big threshold, meaning it's not that everyone below the poverty line looks the same and everyone above it looks the same. It really is a stepwise association. More recently, there was a paper that came out of Ontario that looked at another indicator of health, this time days alive and out of hospital after major elective non-cardiac surgery. Same thing, this idea that if you look across socioeconomic status, this time income quintiles, you see this kind of gradient effect, so that the higher your income level, the better your outcomes, the longer you're alive post-operatively. And if you look at that paper, this sort of later paper, you look at the editor's perspective, what they say is, have a section called What We Already Know, and they say low socioeconomic status likely impairs many aspects of health. It's kind of shocking to say likely at this point. We have, probably hundreds of thousands of papers that have shown this. And they talk about their measure of days alive and out of the hospital. And then they say, what does this article tell us that's new? And they say, well, this is partly about their particular outcome. They talk about, the fact that this is new information in their particular area. But it's kind of curious, because what is a little bit lost in presentations of socioeconomic health inequities, in particular outcomes, is this broader context. So in some ways, it's not enough to just have the first bullet that says, yes, it affects many aspects of health and healthcare. I think the main message of the literature at this point is that it would be novel not to see this finding. And so, we keep doing this. We keep looking at the pattern. And I think we can make an argument that there's some merit to keeping on documenting patterns. But it is worth noting that we are now decades and decades and decades into producing, very similar graphs to this one and to this one. It's routine now. And in fact, you saw it during COVID-19 as well. So brand new disease. And before we even knew how it was spread, we saw that socioeconomic gradients in COVID emerged. And so if you look at these gray bars, again, you see this stepwise association across socioeconomic groups and COVID risk. And so, there has been a lot of work that ties all of this together, that explains why it is that cardiovascular disease and post-operative days alive and COVID and you name it, all have similar gradient patterns. And one of the most powerful ideas that sort of explains how these things work together is called the fundamental cause theory. And this was sort of first laid out nicely in 1995 by Lincoln Phelan, who essentially said what's happening is that socioeconomic conditions are the root cause of so many pathways leading to so many health outcomes. And so if you look at a sort of conceptualization of what they say, it looks something like this. This is essentially saying that socioeconomic status is associated with health outcomes through health behaviors, through stress, through the kind of healthcare access you get, through epigenetic processes, you name it. And socioeconomic status tends to be a root cause. And so their point in laying this out was to say, this is kind of how things are operating. Socioeconomic status doesn't compete with health behaviors as a determinant of health. It doesn't compete with stress or with healthcare access. It is why those things are happening. It is how at the population level, those risk factors are sorted, meaning your propensity to have positive versus negative health behaviors, to experience stress versus not, is sorted across socioeconomic lines. And they say the implication of this is that socioeconomic status will affect almost every health outcome because it affects almost every pathway. They say, look, if you intervene on health behaviors or stress, or even healthcare, as we often do in public health and medicine, you are unlikely to change the fundamental relationship because socioeconomic status will just assert itself through some other pathway. So if you do a program that addresses health behaviors, socioeconomic status is likely to just reassert itself through stress or through X, Y, or Z other mechanisms. So their point in saying that it's a root cause is to say that it has the power to sort of sort health at some, again, fundamental level that is unchanged when you try to meddle with the middle of the pathway. And the World Health Organization Commission on Social Determinants of Health kind of put together the literature that talked about social conditions more broadly, including socioeconomic status. And this is kind of like a glorified version of what I just showed you, in that it suggests on the right that health and health equity are driven by a bunch of pathways, material circumstances, behaviors, biology, psychosocial factors, and that those are sort of sorted or caused by socioeconomic position and a bunch of other social conditions. And perhaps the newer insight at that point was that on the one hand, yes, something like socioeconomic status can be considered fundamental or root, but that it doesn't have to be that way, that socioeconomic status is attached to health and pathways to health because of the way society is organized. And so policies and other aspects of societal conditions could really be thought of as the cause of the cause, as Michael Marmot put it. And so if you look what's happened over time, and you say to yourself, yes, there's socioeconomic gradients in almost every health outcome, but what's kind of the story right now in terms of how we're doing with them? And you could make an argument that, I'm giving this talk today, but I'm sure all or most of you talk about social determinants and health inequities in one way or another and have for years. Canada signed on to treaties to address social determinants of health, et cetera, et cetera. But if you look at what's happening to health inequities, it's actually really discouraging. So this is a slide from a report done by Toronto Public Health back in 2015. So actually in 2005, Toronto Public Health documented what income-based health inequities look like in Toronto, and found that there were unsurprisingly, significant income-based health inequities across a wide range of health indicators. And they decided to address this. So they implemented programs to help people improve their health behaviors. I think things like smoking, breastfeeding, et cetera, et cetera. And the point was to say, what can we do to mitigate these health inequities now that we've documented that they're there? And they went back 10 years later, hence the title of the report, 2015. And what they found is that of the indicators they had looked at, 21 of the 34 had worsened after putting in 10 years of effort to reduce them. And I think you can make a strong argument that this is because we have essentially ignored the fact that socioeconomic status and the societal conditions that produce these relationships are fundamental. Again, you can breastfeed program all you want, but at some level, those socioeconomic conditions, as they stay stagnantly bad or worsen, will always have an impact on health. So if Toronto Public Health at its level is the one addressing health inequities by implementing behavioral programs, it's just insufficient to address the fact that the fundamental issue is low income, is poor housing conditions, is declining job security, and so on. And that's precisely what was happening during this time that they were trying to intervene. And if you look sort of at a more population level across societies like Canada and peer countries, what you see is that, in fact, health inequities are either stagnating or rising, depending on, the country, depending on exactly how you measure it, and so on and so forth. But decades into this, decades of documenting disparity after disparity after disparity, decades of trying to do something about it in public health. And what we have in present day is a worse situation than we had many years ago. And so one thing to sort of stress to you is that while we think of socioeconomic health inequities as a static concept, it is very important, particularly now, to think of it in dynamic terms and to recognize what is happening over time, because that informs how to understand them. So if things are worsening over time, that means I have to account not only for instance, whether behaviors account for health inequities, or X, Y, or Z individual factor accounts for health inequities, but what accounts for the fact that that's worsened over time. So let me switch now to another big topic in the Canadian landscape that has gotten significant attention in the last few years, but has a very, very, I should say in the epidemiological context in any case, but has a very, very long history in other countries, in particular in the United States. So I'm just going to say this really quickly, and I'm very happy to come back or talk about all of this in more detail. But let me say emphatically that racial disparities, racial health inequities are in no part associated with the idea that races have different genetics, because races don't have different genetics. So racial groups are not genetic groups. So even when you have a disease that has a genetic component, when you ask the question, not what causes this disease, but why are racial groups different in a disease, that answer cannot involve genes, because the group itself is not based in genetics. And we have a long history now of population geneticists and others who have been able to tell us exactly how and why it is incredibly wrong to think of racial groups and ethnic groups and immigrant groups and whatever you want to call it as genetic groups. It's not that there aren't population genetic groups in the world. It's that they don't map on, those groups don't map onto what we socially call race, ethnicity. And let me just give you a quick example of just how social racial connections to disease are. This is a map of the United States at the border of Mexico. And in this area of Arizona and Mexico resides an indigenous group known as the Pima Indians. And in Arizona, the Pima Indians have an extremely high rate of diabetes. And there has been a long history of trying to understand what is the genetic risk factor for diabetes in Pima Indians. And this should ring bells for you, because we do this with Indigenous groups in Canada constantly. We try to understand what is the genetic factor out there that could explain why Indigenous groups have high rates of diabetes. So these researchers said, well, we want to know what's happening to the Pima in Mexico. And so when they looked at the Pima in Mexico, same indigenous group, they just had a border bisect their community at some point in history. The Pima in Mexico had 5 times lower rates of diabetes than Pima in Arizona. Same genetic group, 38% a diabetic in Arizona, 7% in Mexico. So, you know, it's really, we have to somehow shed this really incredible urge to attribute race ethnic health issues to genes. And in fact, if you look at the WHO framework and you see that race ethnicity is sort of in this box of social variables with socioeconomic position, with gender, et cetera, you can see what's actually happening in terms of the relationship between race and health is very much like what's happening between socioeconomic status and health, in that what's the primary issue is that race essentially sorts people, and I should say societal conditions force that race sorts people across risk factor groups. So race makes it more or less likely that you have the opportunity to engage in healthy behaviors, that you have more or less opportunity to have good working conditions and living conditions and so on. And those things, and that you have more or less opportunity to be exposed to stress and so on. And so those things happen because of the process of racism. And again, that's why societal conditions matter. There's no essential relationship between race and health. It's happening because that's how we sort people in society to be at higher risk or lower risk. And we do it so insidiously that they become at higher or lower risk for almost every health outcome like out there that is similar to socioeconomic status. And as I'll point out, those two things are very related. Again, here comes COVID, brand new disease. And somehow we managed with a new disease to have major racial health disparities. And again, in the gray bars, you can see that for non-white groups, the percentage of COVID cases outstrips their percentage in the population. And so one of the really important insights from COVID was how maldistributed the disease was, not only socioeconomically, but racially. So if I pare down that WHO framework just for the sake of, ease of understanding the relationships, this is kind of what the WHO framework is saying. It's sort of saying, look, your racial group determines the kind of racism that you are exposed to. And I sort of put a back arrow because we won't have time for this, but sociologists and others and anthropologists will tell you that actually racism determines our racial categories in the first place. They are not natural. They occur because people want racial categories so that they can sort our power and resources across groups in society. So race essentially is associated with racism. So when you measure racial groups, you are largely measuring how much racism people are experiencing, what kind of life conditions people are experiencing. And the idea is that those determine both socioeconomic conditions, they determine the material circumstances of life, they determine your living conditions and your housing conditions and so on. And they also determine how much physiological and psychological stress you experience. So the experience of racism is damaging for health through multiple pathways. One is more material in the sense that it's about sort of not just what you perceive, but what your life actually looks like tangibly. And other pathways have to do with how much stress is caused by racism. So again, you set up this familiar, hopefully, fundamental cause relationship so that if you intervene on racial health disparities by trying to alleviate stress, by trying to teach better health behaviors and so on, but don't intervene on the fundamental causes of racism and how exposures are sorted, you will see these racial disparities happen over and over and over again. And I would argue no better example of that than COVID. It is precisely because we didn't deal with how society sorts disadvantage and risk that even when a new disease happened, you got the same sorting. And I'll talk about that in a little bit. Let me say something about how to think about modeling racial disparities and pick up on one point that I think happens a lot, which is that we often say to ourselves, well, are the disparities racial or are they economic? And we force those things to compete with each other. And so, I've put up the two graphs I showed you about Toronto and COVID risk side by side. On the left, cases have been sorted by race. And on the right, cases have been sorted by income. And so one way to approach this data is to ask if income is confounding, if race is confounding the relationship between income and health, or vice versa. And often we do that in our modeling strategies. We say, well, we need to understand what the relationship is between race and, in this case, COVID, after you account for the relationship between income and COVID. And I would submit to you, we do this very frequently in all sorts of contexts with all sorts of indicators. This is our own work that tried to look at inequities in COVID by various measures of disadvantage: median income, ethnicity concentration, and deprivation. And the idea was to mutually adjust for all social indicators to find out which one is the worst. And in this case, ethnicity concentration was the worst, even when you adjusted out income and so on. But I would submit to you, sorry, I think I had one slide out of order, so I'll just talk about it. I would submit to you that that's actually the wrong way to approach this. And it's the wrong way, if you don't mind, I'm just going to look for that slide so that I can get to it. It's the wrong way to approach it because of the earlier slide I put on, which says actually socioeconomic resources, just like health behaviors, are not competing with social conditions, with race in this case. It's actually part of the causal pathway. And so you don't want to treat factors that are on the causal pathway as confounders, as covariates that are extraneous to the relationship you're trying to explain. And so in the red, I've kind of put in a story, if you will, of what we think is happening. And a lot of this is thanks to the work of people like Sharmisa Mishra and her colleagues, who have been quantifying how and why health inequities are occurring during COVID-19. And effectively, if you start at the right, at risk for COVID-19, a lot of risk was concentrated in people who had to work in person. And a lot of those folks were essential service workers or similarly low income, low job autonomy workers. And the reason that we saw racial inequities in COVID is because a lot of non-white groups, Black and brown groups, were more likely to be in essential service work jobs. And in fact, I will say, I even saw during COVID a news item where a very prominent physician, public health scientist in Ontario, said something to the effect of, it'd be really nice to know why Black people are at higher risk for COVID. And I'd really like to know, is it socioeconomic status? Is it genes? Even in COVID, a brand new illness that we know is airborne, it's almost like we can't help ourselves but to add genes to the mix of risk factors. And I'm telling you, you are barking up the wrong tree by doing so. That if you want to understand racial health inequities, you must understand the social processes that lead to the biological and behavioral risk factors that predict health. And so in this example, socioeconomic status is not a confounder for race or racism. It's part of the causal explanation. And so if you go back to this graph, it's not that income is confounding race or vice versa. It's that racial groups are sorted the way they are, meaning non-white groups are at higher risk for COVID because they are more likely to be in lower income groups. And those lower income groups have higher risk because they are the groups that were out working, et cetera, et cetera. So my pitch in this is to really understand the variables we're dealing with, what they signify, and how they are related to each other. And that's why, I'm going to start today, but this is often a case by case, sort of problem to solve about what is it that you're actually modeling when you're modeling race and socioeconomics. Another variable in the racial inequities mix that's really important is immigrant status. And so for a long time, Canada had a history of studying immigrant differences in health status, both in terms of whether you're an immigrant or not, and the time since immigration or the generation since immigration. And this is a graphic of a study we did some time back where we looked at racial differences in health status across a variety of health indicators for the US and Canada. And one thing you'll notice is considerable variability across health outcomes. So it's actually not the case in this data that all health outcomes are worse in people who are non-white. And you'll notice at the bottom that we did adjust for everything I just told you not to adjust for. And that's partly because journals at that time at least, had a really hard time accepting not controlling for these other variables to get some sort of very conservative estimate of race, because it's also true that socioeconomics have a distinct relationship with health aside from their relationship to race. So these are not easy kind of things to think about modeling. But in relation to immigrant status, there's a sort of push-pull story happening, because as many of you know, newly arrived immigrants often have better health, and their health tends to decline over time. Newly arrived immigrants also tend to be non-white. In large numbers are non-white. And so if you look at the relationship between race and health in Canada in particular, with such a heavy influx of immigrants, you have to consider what the effect of immigration is in the relationship you're modeling. And I would submit again that it's not adequate to control for race. We have to really think about what we're doing when we control for a variable. And I think instead what you want to understand is what the interaction is, how race operates at different levels of immigration. That is much more informative and true to the data. But again, if nothing else, please take home that there's no, often there is a right answer, but there's no sort of easy way to translate this into every study. It really is a question of being thoughtful and having people involved who understand social data in relation to health. Another big issue for us in Canada and Ontario is the relationship between aggregate data and individual inferences. So this is a map of COVID risk. And early in the pandemic, this is all we had. We would figure out how cases in Toronto were distributed across neighborhoods. And the idea was that by doing so, we could maybe take a guess, a starting point at what the risk factors were, how COVID was spreading through the population by understanding how it was spreading through neighborhoods. And the darkest blue shade is the highest rates of COVID, which happen in the northwest region of Toronto, which has a heavily working class Black population. And so that spawned hypotheses that said it is working class Black and brown people who are most at risk of COVID. But we have to think a little bit when we have aggregate level data about the inferences we're making. So at the population level, that's what the neighborhood story tells us. We're not sure if it's an individual level story until we kind of probe the data. It turned out it was the story, but this is to flag for you that when you're using aggregate measures and individual outcomes or individual level measures as well, it's important to know what the relationships are and the significance is, again, the meaning of the variables that you're using. So we often use ONMARG, the Ontario Marginalization Index. And the question, I have this question about the index itself and what indicators are involved in it and how they interact with each other. But aside from that, I think we want to know whether ONMARG is meant to represent individual level deprivation or area level deprivation, in what context, et cetera, et cetera. So let me just end with an example of what I think is what we'd love to test, and talk a little bit about what we can test with our data. This is an article from the journal Circulation, where a team essentially said what we started out with in the presentation, which is that there is a society to cell relationship that explains health inequities. And so what they said is, look, at the very bottom of this flow chart, you've got poor cardiovascular and stroke outcomes. And they're effectively saying, this keeps happening. It's not going away, and we need to understand what's happening. And so they basically say, this at the most proximal level is a function of exposure to stress and other cardiovascular risk factors, diet, exercise, whatever it is. And they're saying those, you can't stop there. Those are a function of a bunch of social conditions, living conditions, healthcare conditions, housing conditions, poor access to capital, to wealth, school funding, and so on. And they say that's, you can't even stop there because that's happening for a reason. And they go back in history to kind of understand the trajectory of US society that led us to a point that in present day sorts risk for life experiences and health behaviors, and you name it, sorts that risk across racial groups and across socioeconomic groups. And so they talk about the fact that, you know, if you go back to the very beginning of US society, you can see the genesis of this. You can see that slavery and structures to maintain white supremacy and Jim Crow laws. I can talk to you about all the details of this later, but a set of societal conditions, formal and informal, led to a society that in mass quantities, in pervasive and insidious nature, changes the life experiences and trajectories of Black people compared to white people. And that, yes, we see cardiovascular disease and stroke outcomes in our clinic. And yes, we know there are differences in living conditions, but their point is all of this has societal roots, that this whole thing works together, and it's very difficult to intervene in the middle and expect anything to change. And I would say, I think I'm missing a slide here, sorry. I'll just say it. So there, if you look at COVID in Canada, you could make a similar argument. So if you started with COVID at the bottom and you say, well, what was the main risk factor or risk factors for COVID? Well, the number one thing was indoor air exposure and chronic repeated indoor air exposure. Why did that happen? Well, people have low income, low autonomy jobs. You know, they live in crowded conditions in segregated neighborhoods where there's high levels of essential service workers. So even when you're not an essential service worker, people in your apartment building are, and in your grocery store are, and on your bus are, et cetera, et cetera. And so there are this set of living conditions that set up the circumstances that set up the indoor air exposure. Why did that happen? Why was it that Black and brown people have that apartment exposure and grocery exposure and the bad jobs and the multiple generations with those bad jobs, et cetera? Well, there is a long history in our country of policies and sort of historical trajectory that also starts with establishing structural conditions to maintain white supremacy, and has trickled down in various ways through laws, through sort of de jure, sort of accepted forms of racism in the labor market, and so on, in our immigration policies. And so the idea is that ultimately, when we want to understand racial disparities, this is kind of what we want to understand. Now, modeling this and measuring this and the parts that we take on are a whole other story. And most of the time, we take on the very bottom of this flow chart. Sometimes we include some of this sort of meso stuff, but very rarely are we getting to the top. And what I submit to you is that it means we have limited understandings of what's happening, limited evidence, and at some level, we are running our interventions based on this very limited perspective on what drives inequities. And I'll leave it there and hopefully have some time for discussion.
Great. Thank you so much, Arjumand. That was really informative and lots to think about here. So I'll definitely open the floor for discussion. I see there's a few things coming in through the chat, but Sue, if you want to start and go ahead.
Yeah, I guess, thank you, Arjumand. That was wonderful. Wonderful to think, let me learn how to lower my hand. Wonderful to reflect on how a research institute that deals in population-based data, where there's only certain things available, has dealt with some of the issues that you raised. Some well by describing things and showing variation, maybe other instances not so well in terms of really understanding the constructs that are being measured. Do you think there's a role in your big flow chart at the end for trying at a population level to get some of those additional some of those additional levels of your chart, right? Because there are structures within governments that might have information on households or, how and where people are living, and not to put them in a model to explain it, but to help peel back the onion a little bit. I'd be curious if you thought that there were sort of population resources that we might think about.
Yeah, it's a great question. And I think in many ways, ICES has started to try to peel back the onion. So if you think about the fact that there's a move or even questions about, can tax data come in? Can social assistance data come in? This is done because we're recognizing that a lot of the social variables of interest really are fundamental to understanding what's happening. And so the question of whether we can go further back in the flow chart, I think we can at least try. So I think it requires working with social science colleagues to understand what data is available that might be able to be linked in. But I think also, these are active conversations that are really challenging. So if you look at the epidemiological literature right now, there are a lot of debates about how we should measure structural racism, how we should measure these policies and other kind of forms of institutional examples of racism, rather than just asking people, what are your experiences? If we actually want to measure what it is about societies that's, getting this wrong, how do we do that? And there isn't a clear answer. So the going explanation right now, or the going kind of bid on how to measure this, it is looking at whether we can look at the neighborhood or in the US county level and say, okay, what is the proportion of Black people compared to white people who are unemployed? And if you have neighborhood A or county A where white people are unemployed at a rate of 3% and Black people are unemployed at a rate of 7%, then you create some kind of ratio or difference measure, and that's your measure of structural racism. And on the one hand, it makes sense because there's no other reason but racism that you would have systematically different unemployment rates across racial groups. At some level, you get back to racism, whether it's in the labor market, whether it's immigration policy, et cetera. There's no other way to explain that social groups based on race are employed at different levels. But on the other hand, is structural racism continuous that way? So if I have a lower ratio of unemployment, then, if neighborhood B has a slightly better ratio, is it slightly less structurally racist? It's hard to say. It's hard to say if that's actually a continuous measure. And so I think having these conversations, figuring out what data are available, talking to social scientists, talking to the government about how they monitor these issues, whether they have data on them, connecting to StatsCan, and for the love of God to release that data. It all matters and it all helps. The other thing I would say is that I think people in the health world would do well to talk to people in social science areas where they regularly evaluate the effects of social policies. So, because I live in that world, we tend to use econometric methods much more than we do epidemiological methods. And so just knowing what methods are available to do this work sometimes triggers ideas about what one could do, even absent direct data. So sometimes if a policy changes, you can test the effects of that policy, even if you don't have an actual marker for the policy.
Thanks. That's really helpful. And I think, I mean, doesn't even touch on issues of, I mean, you mentioned sort of smaller geographic units for getting at some of this and some of the privacy concerns and who needs to be, you know, both from a data protection perspective, but also from an understanding the data perspective. Yeah, and building across, for example, of getting data from governments, even sharing within them and like within the Ontario, right? Lots of really interesting things to think about.
I see a comment in the chat. We usually don't have access to policy levers that can directly, in this context, how can we design health and yeah, Calvin, it's a great question. You know, unfortunately, I really don't have a lot of examples. So I actually don't have examples even of non-health researchers, though. And that's why health inequalities are worsening, because the policies we've been implementing tend to be worse for poorer people than they ever have been. So we, over the last many decades, have gone backwards in terms of how generous our social policies are. And I'll give you some perspective that a former student of mine, who's now at Institute for Work and Health for us, Vahid Shahidi, gave me. So some of you may recall that a few years ago, there was an effort to implement basic income in Ontario, and there was supposed to be a basic income pilot, and it got canceled. And the idea was we could replace social assistance with an across the board, don't have to apply for it benefit that would be more generous than social assistance, and more importantly, would cover more people. You don't have to qualify you just have to meet the income bar and away you go. Because one of the other things that's happened over the course of decades is fewer people are eligible for benefits than ever before. And Faraz reminded me that this is all good and well. I'm sure basic income is better than what we have, but the amount being proposed for basic income was less adjusted for inflation than what social assistance recipients used to get in the mid-90s. You know, what can you say to that? What can you say to that? Our horizon of what can be done and what we're willing to do and what we expect of our governments has significantly narrowed. And so, Calvin, what I might say, even though I don't have a good example for you, is that a couple of things. One, I think recognizing the world of possibilities compared to the world that we kind of every day live in terms of what to do about health inequities is step one. We need to at least recognize that we are severely limited in what we imagine we can do. And I would say the other thing that jumps to my mind is that just recognizing the idea that people in the healthcare system cannot implement healthcare interventions that will fix this, and understanding that probably your most important power is to use your status to influence and to participate in social movements and policy processes outside of your everyday work. It's a hard truth. It's a very hard truth. But there you have it. Like, admitting that you can't do much is a big deal.
Really appreciate that response, Arjumand. And I'm getting a couple of questions come through anonymously in the Mentimeter, some of which I'm going to group with a few questions that came to us in advance related to kind of the data itself, or disaggregated race data. And so I guess I'll just quickly recap some of the gist of some of the questions or discussions I've heard, which is people speaking about kind of this double-edged sword of race data, where some folks are worried about kind of getting cut by this lack of data collection, or not having the right data to be able to paint this picture at those kind of macro or meso levels, as you described today. whereas others are worried about getting cut by data collection, either being used to delay actual action, or perhaps the data being collected inappropriately or analyzed inappropriately, leading to more discrimination if kind of collected in this kind of colonial perspective, perhaps if those structures of white supremacy haven't really been debunked. So perhaps it's a bit of a chicken and egg scenario, but wondering if you can maybe describe the nuances of this dilemma a little bit further for us, or perhaps comment on opinions that either you hold or that you've heard.
Yeah, it's a great question. So for full disclosure, I'm Canadian, but I was trained in the US and worked in the US for a long time. And so my perspective on this is very influenced by being there and by working with social scientists there, by working with health inequity scholars there. So I understand the idea that data could be collected inappropriately and used inappropriately. I must say I'm not an expert in understanding how data should be, housed, governed, etc. So please take all of this with a bit of a grain of salt. In my view, the benefits with safeguards of having data that tells us what's happening to society far outweigh the risks. In other words, I think transparency is probably the best way out. Ironically, I think transparency and having the information is the best way to prevent misuse. So let me give you some more concrete examples. The misuse and mischaracterization of race in health sciences is rampant. And I will say, including with ICES data and ICES scientists, full disclosure, no question about it. I won't give you examples, but I could. And yet I think the way to make sure this doesn't happen is to make that data available so that people can see for themselves what's wrong with it and can reanalyze it. So a colleague of mine at McGill, Jay Kaufman, has done this many times. He looked at a study led by a University of Alberta scientist some years ago for a cardiovascular medication that they wanted to market as a race-specific drug. And their argument was, well, we did a randomized trial, and it turns out that Black people responded differently than white people. And so they unrandomized their trial and looked at racial groups differently. And they were, going through the FDA process to, authorize this medication on racial grounds based on this study. And my colleague, Jay Kaufman, and his colleague they got the data, they reanalyzed it. And what they said is effectively what you've done is organize the results around race, but actually what you're missing is that racial groups were sicker in your study. They were poorer. They were less likely to be on medication. So all the risk factors were different than they were for the white population. And so this is not a drug for Black people versus white people. It's a drug that worked when you have a risk factor profile like X or Y. So in my estimation, you want to shine a light on these things. And I'm glad you said, what's your personal view? My personal view is that I would rather have a public record of what is happening in our society for, in terms of race, than to not have any documentation of population level patterns on this. So even if you told me nothing happens with the data, I'm actually okay with that. I don't expect, I'm not of the view that all of a sudden the data will get collected, it'll get analyzed, and that's our magic solution for action. I don't believe that, unfortunately, but I don't. But I still think we need to know what's happening, and that it is a piece of evidence that people use in social movements. It's a piece of evidence that we use to understand what our society is about and what it's like. And the last point I'll make on this is that it's also important to know whether interventions are working or not. And so again, this is the moving things from a static perspective to a dynamic perspective. It's one thing to measure racial disparities. It's another to know if racial disparities improved or worsened when X, Y, or Z intervention was put in place, when X, Y, or Z policy changed. And it's not enough to have anecdotes. I mean, this is the idea that this is also colonial. I would really challenge the idea that, you know, counting things and having systematic science on things is a colonial approach. That's baseless. Math and science were not invented by white people, you know, in Western Europe and Canada and the US. So yeah, there's a lot of parts of that I don't subscribe to. Now, is it legitimate that data gets misused? 100%. Is it also legitimate that data gets misused in other ways, like it's owned by private companies and then gets accessed for nefarious reasons? Absolutely. And I think people with better expertise than mine need to sort of take a look at that. But I still think there is huge merits to collecting the data and understanding what's happening at a systematic level.
Thank you so much for your insights. There are a couple follow-up questions in the chat and more questions coming through on the Menti, but I see we're kind of at time. So perhaps we can pick up the discussion at another time. A lot to unpack here for sure.
Happy to. Thanks so much for having me.
So Laura, did you want me to proceed with the closing?
Yeah, absolutely. Thank you so
Okay.
much, Arjumand, also for taking the time to answer some of these questions. I know there's probably many more coming in, but even the starting discussion today was just so helpful. Yeah, Sue, I'll pass it to you.
We could probably, like the ones that weren't addressed, even to send them to Arjumand, just so she
happy
has
to. Yeah,
their,
sure. Happy
to know. So that might be really helpful. So thank you so much, Arjumand, for
Pleasure.
providing us with such an engaging session. So many key points to take away. I was struck when you urged us to think of socioeconomic constructs as a dynamic construct over time. Also, your continued urging to think deeply about how the constructs of race and socioeconomic status interact with each other, individual and aggregate levels, and how that can sometimes not come through fully in work. So thank you everybody who came and attended the session today and for your thoughtful questions. I hope we can continue to reflect on these themes as we move forward in our research. Hope everyone has a nice weekend.
Yeah, have a great weekend, everyone.
Great. Thank you, everyone. Take care.
Bye.